Dr. Akasaka. Actually, now there are various modalities that are being used in the cath lab like IVUS, OCT, and the QCA. So now I call Dr. Akasaka to speak on principles of imaging with a focus on strengths and weaknesses of each modality.
Thank you.
Dr. Akasaka is a professor of medicine in Division of Cardiovascular Medicine, Wakayama Medical University, Japan.
This is my disclosure slide. As you know very well, there are each modality may have an advantage and disadvantage as shown in this slide. OCT may have an advantage in the resolution 10 times more than IVUS, as you may know very well. And also tissue characterization is quite easy compared with other modalities. But IVUS is very easy to use without contrast. There are some advantage and disadvantage. Based on the angio guide, we use an image guide several times. And if you use an IVUS, as shown in this slide, we can measure the external lumen area. That means the vessel area and also the plug area and also the lumen area. And based on this guidance, we try to decide stent size and length, as you know. And if you use an IVUS, this is an adapted sub-study. If you use an IVUS, we can reduce the MACE as shown in this slide compared with angio guide alone. And how to change the procedure demonstrated in this slide. If you use an IVUS, we use the larger size balloon and higher pressure, and after putting a stent, we decide post-dilatation because of under-expansion and the malposition, and we sometimes try to do the additional stent. So nearly 75% of cases, we change the strategies based on IVUS guide. And this is a meta-analysis demonstrate how IVUS is better than the angio guide as shown in this slide. And all the data demonstrate IVUS guided PCI might be better than the angio guide, as you know very well. I try to show you the one case, 70 years old female, the non-STEMI case. This is a still frame of angio. There are significant left main and bifurcation stenosis. Then when we treat the patient, we put IABP in this case. And this is an IVUS, a little bit, yes, it takes a little bit time. Pull back from the distal to the proximal, we can identify the plaque and also the stenosis. Here is the bifurcation, lots of plaque here and the left main. This is after 2.5 millimeter balloon dilatation. Here is an orifice, so lots of plaque even in left main. Then this is a still frame. We analyze the vessel area and the plaque volume. And as you may know, this is an intravascular derived minimum lumen area criteria for functional significant left main coronary artery stenosis. In case with a stable effort angina, we always use the FFR to decide the indication of PCI. However, sometimes imaging is very useful. This is based on the Assam Medical Center result. The speculation of FFR less than 0.80 is in Asian patient, lumen area less than 4.5 square meter, as shown in this slide. And it might be different in a US or European patient. And another advantage of IVUS is IVUS marking. We try to identify the position of the stent by making IVUS marking. Here is an IVUS transducer, and here is the best position to put a stent, right? Then we check the position of the stent as shown in this slide, and then I put the stent. And here is a pullback after stenting here, and the position should be very nice. And we try to check the bifurcation region. Here you can identify the bifurcation soon. Still small under expansion in this position here. And then check the left main orifice, right? And then we do the kissing balloon as shown in this slide, and because of a little bit under expansion, and after kissing balloon, we can get a better MLS site as shown in this slide. And the final, yes, angio demonstrate a very wonderful result. And there are some rules, 5, 6, 7, 8 square millimeter rules if you try to treat the bifurcation lesion by IVUS. And this is another case. It is very useful to demonstrate IVUS in case with CTO. This is an angio. You can identify the complete occlusion in the just distal of the diagonal branch. And right, here is another view, right? So you have a big diagonal branch, however, there are abrupt occlusion. So Japanese CTO score demonstrates this is a blunt occlusion, and the total point is 2 points, so intermediate difficulties, right? So using the IVUS, we can identify the position of the wire. In B, you can identify the wire position, and then the C demonstrate LAD. You can identify the wire position. We can confirm the position of the wire by using IVUS. So we identify the true wire position by using IVUS guided CTO treatment. And then this is the real world. You can see the IVUS probe here, and then we can confirm the position of the wire here, and then we can insert the wire as shown in this slide, and the success rate will increase if you use an IVUS guided PCI. And then this is the final result. Okay, the result is very fine as shown in this movies. And then this is a state-of-the-art paper in the expert, right? If you use an IVUS, stent deployment is very easy, especially in complex lesion, and we may reduce the stenosis and stent thrombosis and reduce the mortality if you use IVUS with an angio guide. Therefore, the guideline in ESC demonstrate 2A recommendation. However, the OCT is still 2B. But as you may know, I already explained you, the OCT may have a much higher resolution and easy to demonstrate the tissue characterization. In case with a fibrous plaque, OCT demonstrates signal-rich homogeneous, and calcium, you can identify the signal poor clear border. It's quite easy to delineate. Here is calcium, right? And then fibrolipidic, you can identify signal poor diffuse border. It might be very difficult from where the lipid start, but anyway, you can identify the signal poor region. Here should be the lipid. So if you know that this pattern, more than 90% accurate to identify the tissue. So compared with IVUS, it's much more easy. And this is a true clinical case. The left-hand side demonstrates fibrous, right, signal-rich homogeneous, and calcium upper center demonstrate 360 degree circular calcium, and the bottom demonstrate nearly a 2-quadrant calcium, and this is 60 degree calcium. And lipid is in the right hand upper panel from 9 to 2 o'clock, and the bottom demonstrate from 2 to 11 o'clock. It's quite easy, right? So, but real practice is a little bit different. This is 360 degree calcium in the left-hand side. However, you can identify some high signal with shadow in around 6 to 7 o'clock. This is a cholesterol crystal deposition or farm cell deposition. So the tissue is not very homogeneous, it's very heterogeneous. Right-hand side, much more complex. You can identify several spotty calcium here and here and here, and from 3 o'clock to 6 o'clock, there are diffuse border low signal poor region. This might be the lipid. So the true plaque is much more complex. This is mixed plaque, as you know. So Based on these data, there are lots of consensus documents to recommend OCT in clinical practice, and this is an expert review, and also this is expert review. And this is one of the data showing the OCT is superiority compared with an angio-guided PCI. If you use an OCT, death rate and cardiac death and also the myocardial infarction is significantly smaller than angio-guide. It is a retrospective single-center study. Why we can expect this data? Because in the measurement compared with a phantom model, OCT is quite accurate and IVUS always overestimate. In the real clinical practice, IVUS always overestimate compared with OCT, and QCA underestimate the size. And reproducibility of the sizing of OCT is better than IVUS in this report. And then we try to demonstrate the OCT non-inferiority compared with IVUS guide based on the opinion study as shown in this slide. And this is an guideline criteria how to optimize the OCT and IVUS guided PCI. And we try to avoid the landing zone, the lipidic plaque, because as shown in this slide, if the landing zone is lipidic, there are significantly higher restenosis, HD stenosis rate compared with fibrous and fibrolipidic, as shown in this slide. And the opinion study demonstrate non-inferiority of OCT compared with IVUS. And the secondary endpoint also the non-inferiority. This was already published in European Heart Journal. And another study, similar study, is Illuminant 3. They try to demonstrate OCT non-inferiority compared with IVUS and OCT superiority to angio-guide, right? And they succeed to demonstrate non-inferiority of OCT guide compared with IVUS guide as shown in this slide, but they failed to demonstrate the superiority of OCT guide compared with angio guide because of the smaller patient population. And this already published in Lancet, and based on this data, they recommend to do the much bigger number study, prospective study, to demonstrate OCT guided superiority compared with IVUS guide. And there are some difference in opinion on the Illuminant 3 because endpoint is different. Opinion demonstrates a clinical endpoint, and Illuminant is just post-PCI result. And also the stent size decision is a little bit different. Opinion demonstrates based on the lumen, and we recommend quarter size bigger based on the lumen diameter. But Illuminant, they recommend media to media, the vessel size, a little bit different. But still, there are some discussion about the how to decide the stent size. We need some data, much more data. And so based on this data, we are expecting the OCT guided PCI should be at least 2A in guideline. Then, based on this experience, in our institution, we use more than 90% image guide PCI, and IVUS guide is only 20 to 30%, especially in left main or RC orifice and CTO, as I already demonstrated. And OCT guide is 70 to 80%. Almost all cases, we can do the OCT guide. And this is the comparison of an imaging guide versus angio guide meta-analysis. And the imaging guide reduces the risk of cardiac death and many adverse effects. They compared finally 31 studies and IVUS guide and angio guide and OCT guide as shown in this slide. And this is network summary statistics for all cause of death. Compared with angio guide in the top left-hand side, IVUS and OCT is superior than angio. And if you do the rank probability analysis, OCT should be the best, as shown in the right-hand side, and second should be the IVUS, and angio is an inferior than image guide. And this is the main analysis for a secondary endpoint. Red color demonstrates significant increased risk for outcome of interest. So compared with angiography, IVUS OCT demonstrate better in MACE and cardiac death and myocardial infarction. Also, the target lesion revascularization and stent thrombosis as shown in this slide. And the OCT have a higher resolution, as I told you. Previously, we tried to measure directly from the strut position to the vessel wall to identify the incomplete stent apposition distance. But because in EES science, if the incomplete stent apposition is more than 350 micron, it still continue even 6 months or 8 months after stent deployment. However, the incomplete stent apposition distance is less than 350 micron, it will disappear. So leave it alone, okay. But recently, the OCT developed very much, and we can identify the incomplete stent apposition by color demonstration as shown in this slide. In this case, red color demonstrates more than 400 micron, and the yellow color is more than 200 micron. Therefore, you can identify lots of incomplete apposition in the proximal site. And this color bar is very useful. Red color is here in the right-hand side, and almost all white color. So we still try to do the higher pressure ballooning or bigger balloon in the proximal edge, as you can speculate. And also, OCT may have an advantage of the calcium identification and identification of the thickness of calcium, as shown in this slide. Here, distal portion is a calcified nodule, and you can identify 360-degree circular calcium in the mid portion and proximal site. Then we decide to do the rotablator, and you can identify clearly the ablation portion, cutting surface here and here clearly. And then you can select the bar size based on this image. And then if the calcium thickness is less than 500 micron, you can make a calcium crack using higher pressure. And if you have the crack, you can get the bigger stent area, as shown in this slide, if you put a stent after higher pressure ballooning. It is very important to reduce the in-stent restenosis. So the make a crack cutoff value should be 500 micron based on this ROC analysis. And this is a result of calcium fracture and with or without calcium fracture. If you have the calcium fracture, and if you put a stent, you can get a bigger minimal stent area, and stent expansion index is better than the case without calcium fracture. And this is a 10-month follow-up data of target lesion revascularization. If you have a calcium fracture, you can get a bigger stent area and better stent expansion and reduce the binary restenosis and target lesion revascularization as shown in this slide. So it is important to identify the calcium fracture. And recent development of OCT can demonstrate clearly the 3D reconstruction of the stent position, especially in the bifurcation region. You can identify the stent strut and also the guide wire as shown in this slide. Here is one of the example. Left-hand side is the distal and right-hand side the proximal. Wire is actually, you can succeed to select a distal cell. However, here is a rink. If you dilate here, you still have the strut at the center of the orifice. So this is not the best position to select the wire. You can try the rewiring again. This is another view of the 3D reconstruction. So the position of the link is by chance, as you know. Here is some explanation of the link. There are peak-to-valley DS Zions and peak-to-peak DS Synergy, Onyx, and Altimaster. And here the left-hand side demonstrate link-free type. There are no significant link at the orifice, but the right-hand side link connecting type, here is the link at the center of the orifice, bifurcation orifice. And if there are some link connecting type, carina type, you cannot get a good result as shown in this pilot study by Dr. Okamura. And this is one of the example. This is link-free time, and the wire can succeed to insert the distal cell. And if you do the kissing balloon, and you can get an optimal result, very big side branch orifice. And this is a suboptimal result because there are some link here. And if you dilate, still you have lots of stored at the orifice. And this is another example of a link connecting carina type and suboptimal result. A link is indicated by the green circle, and if you dilate here, still there are lots of stored at the orifice. So if you use a 3D reconstruction by OCT, you may reduce incomplete stent apposition and potentially could expect a better result. We did a 3D OCT guided PCI in Japan, a small number of registry. In our daily clinical practice, you have to rewire again nearly 30% cases by OCT guide. And we try to compare the result in case with better optimal and suboptimal case. You can not select the position of the link, so it's by chance. So link-free type and link connecting type is a half and a half nearly. And even in link-free time, you succeed to get an optimal result only 54 cases in this registry, and suboptimal result is 51. And we did not demonstrate any clinical difference. However, this is one of the jailed stored percentage. In suboptimal case, there are lots of jailed stored at the orifice. And there are tendency of instant restenosis long-term follow-up, but the number of registry is not so big. Therefore, we try to do another registry more than 600 cases, which demonstrate the clinical significance of an advantage of 3D reconstruction. Now, finally, I would like to show you the importance of instant restenosis tissue characterization. We are expecting a very nice result in the left-hand side, a small amount of neo-intima with a very high signal, which demonstrate fibrous tissue. However, there are some instant restenosis shown in the right 4 cases. This is a fibrous, this is a proteoglycan rich, this is the heterogeneous and layered. And based on these findings, we can select the treatment. We are not sure the comparison with histology. We are not sure which one is which tissue. However, anyway, we can say this is a fibrous tissue, and this might be the proteoglycan rich. And if you identify the homogeneous type, paclitaxel-coated balloon, drug-coated balloon should be much more effective than the ordinary balloon as shown in this slide, and some advantage in layered type as shown in this slide. And also higher back scatter, paclitaxel-coated balloon demonstrate much better result compared with ordinary balloon. So you can decide based on such OCT findings, and this is already demonstrated. So this is my take-home message to you. Similar to IVUS, OCT-guided PCI could be useful to improve the result of PCI and clinical outcome, and Class A recommendation at least might be expected in OCT-guided PCI in the near future, although there are several advantages and disadvantages in IVUS and OCT, and also the QCI, as you may know very well. And OCT can replace IVUS in almost all cases in daily clinical practice, except for several specific conditions such as left main or RC orifice lesion, CTO, and chronic kidney disease, and so on. And OCT may have an advantage to know the pathophysiology of ACS, in-stent stenosis, severe calcified lesion, and I did not show you the BRS implantation, but and also the 3D reconstruction